Nowadays, most of the companies are providing work from home jobs for IVR coders. So, in order to help the coders who are planning to get work from home jobs, I am creating this video. So, if you want to have work from home jobs, please watch this video until the end. So, here approximately we are going to learn 50 plus most common IVR interview questions and answers. And also, if you are looking for medical coding jobs in UAE, USA and India, please join in our WhatsApp group, which is in the description of this video. And also, if you are planning to undergo same-day surgery training, IPDRG training, SCC code training, CCS certification, please send message to 707-526-3939. So our first question is, what is interventional radiology? Usually we will call it as IVR. So IVR is a medical specialty which uses real-time imaging to perform minimally invasive diagnostic and therapeutic procedures. Okay. So now we need to understand in IVR we have two types of codes. For procedures we will use 3 series, as well as radiology imaging we will use 7 series. So basically here IVR is the combination of 3 series as well as 7 series codes. So these IVR procedures will reduce surgical trauma, complications and recovery time, as these IVR procedures are non-invasive procedures. Why means in IVR procedures, physician will not create very large incision, so he will create very small incision and he will insert catheters and tubes in order to perform IVR procedures. What are the types of IVR procedures? So basically we have two types of IVR procedures. Vascular IVR as well as non-vascular IVR. What are the examples for vascular as well as non-vascular procedures? For example, if you want to tell vascular IVR procedures, lower extremity vascularizations are the examples for IVR, vascular IVR procedure. For example, if you see fine needle aspiration, where physician will use the imaging guidance in order to perform the procedure, which will comes under non-IVR procedure or non-vascular procedure. Next one, what are the common imaging modalities we will use in IVR? So basically in IVR documentation you will see fluoroscopy, ultrasound, CT and MRI. So the use of these imaging modalities is to provide real-time visualization during the procedure. Next one, what is the difference between IVR as well as normal surgery? In normal surgery, physician will create open incision as well as dissection of the tissue, as well as in the laparoscopic also physician will perform the incisions using anesthesia. Whereas IVR procedures uses the imaging guidance and physician will insert catheters through the percutaneous approach. In IVR procedure, physician will not create large incision. What is vascular IVR? So vascular IVR involves procedures performed inside arteries as well as veins. Most commonly we will see angiography as well as angioplasty, stenting, embolization and thrombolysis. So if you want to know more about angiography, angioplasty, stenting, embolization and thrombolysis, please comment in the comment section of this video. I will create one video related to angiography, angioplasty, stenting, embolization and thrombolysis. So tell me few examples for non-vascular IVR, where physician will perform vascular procedures on other than blood vessels. Examples include abscess drainage, nephrostomy, biliary drainage, biopsy as well as tumor ablations. Why means all these procedures needs imaging guidance. Why vascular IVR is more complex than non-vascular IVR coding? So in order to code vascular IVR procedure, you need to understand vessel hierarchy, catheter navigation as well as vascular families, which we will see soon. Whereas in non-vascular IVR procedures, you no need to understand these hierarchies. In non-vascular IVR, directly you will access the organ where you want to go ahead with the procedure. So what is the catheterization in IVR? So catheterization is the process of insertion and navigation of catheter through vessels for diagnosis or therapeutic procedures. So using the catheterization, patient will inject the injections, pressure measurements as well as delivery of therapeutic devices. Next question. What is non-selective catheterization? So in non-selective catheterization, the catheter remains in the main vessel such as the aorta or vena cava. For example, if you see here, patient will insert the catheter through femoral approach and he will go up and he will reach here in the aorta. So here, patient will not cross this aorta, he will stay in the here only. So this is, we will call it as non-selective catheterization. For example, if the physician pushes the catheter through this left subclavian artery, left common carotid artery, innominate artery, like these are the branches of aorta, then you will call it as non or selective catheterization. So just very simple, if the catheter tip position is in the aorta, you will call it as non-selective catheterization. Okay. If the selective catheterization means if the patient inserts catheter into the branches of the aorta and if the catheter tip is in the left subclavian artery, left common carotid artery, innominate artery, you will call it as selective catheterization. So next question, how do you decide whether catheterization is selective or non-selective? So basically, whenever you want to code IVR procedures, we will decide selective or non-selective based on catheter tip location. If the catheter tip is in the aorta or vena cava, we will call it as non-selective catheterization. If the catheter tip is in the branches of the aorta, we will call it as selective catheterization. Why is selective catheterization considered more complex? So during the selective catheterization, patient needs to navigate through the multiple vessels branches with higher technical difficulty. So because of this multiple vascular branches, patient needs to spend more time as well as it will be having clinical risk as well as documentation requirement. So next question, what is the golden rule in the catheterization coding? Always code based on the catheter tip location. For example, patient inserted the catheter through thoracic aorta and he will go to innominate as well as right common carotid, right internal carotid and right ophthalmic. Here we need to code right ophthalmic, which is the last portion where patient will keep the catheter tip. So here we will not code first order, second order, third order. We will code beyond third order, but based on IVR coding guidelines, we don't have any separate codes for beyond third order. We need to code third order CPT code only. Next question, what is vascular family? So vascular family is group of vessels that arise from a primary branch. Otherwise, network of vessels that arise from a single branch from the aorta or vena cava. Next one, network of vessels that arise from the access site is called as vascular family. Whenever we code IVR coding, we will code based on the family hierarchy rather than individual vessels. Next question, why are vascular families important for coders? So if you understand vascular families appropriately, it will prevent over-reporting multiple vessels within the same branching system. In surgery coding, IVR procedures are having more reimbursement value. So in order to prevent the errors, we need to understand the vascular family as well as catheter tip location. Next question, what is a first order vessel? So this here it is the first order vessel. See, vascular families for interventional radiology coding. This is arterial vascular family and we have vein as a vascular family also. Okay, arterial vascular family as well as venous vascular family. So here is the first order. So what is first order? So a first order vessels arises directly from the main vessel such as the aorta. So it represents the first level of branching. For example, if you see here, this is the thoracic aorta. So this is the main vessel. From the main vessel, first order will come. Otherwise, the branch of the main vessel is first order. So what is second order? So it is simple. The branch of the first order is called as second order. Simple. So here innominate or brachiocephalic is the first order vessels, and second order is right common carotid and right subclavian. All these are the second orders which are come from innominate or first order vessel. So next, what is third order? So basically simple, the vessels which come out of second order is called as third order. So for example, if you take right common carotid in the second order, so right internal carotid and right external carotid which arises from right common carotid, so these you will call it as third order. If the third order divides, again if you see these arteries in the documentation, you need to consider them as beyond third order. As we have discussed previously, we don't have any separate codes for beyond third order. We need to use common code for third order as well as beyond third order. So what is beyond third order vessels? So basically beyond third order vessels are very complex vessels arises from third order. So beyond third order represent very deep and complex selective catheterization. So I have one question for you. If the patient insert the catheter in the thoracic aorta, so what type of catheterization it is? Selective or non-selective? Please mention in the comment section of this video. Next, what is Appendix L in vascular coding? So basically Appendix L is a visual vasculatory guide showing arterial and venous branching patterns. Okay, so which will help coders to determine vessel order and vascular families. So for example, if you see here, this is the arterial vascular family. Okay, so if you go down, we have venous vascular family also. So if you go down, so this is the venous vascular family. Okay, so if you go to interview, they may ask you, what is the difference between arterial vascular family and venous vascular family? Okay, in arterial vascular family, we have how many total? 4 orders: first order, second order, third order, and beyond third order. Whereas in venous vascular family, we have only 3 orders: first order, second order, and beyond second order. So if you go to interview, they may ask you, what is Appendix L or Appendix G? In AAPC CPT book, it is Appendix G, whereas in AMA CPT book, it is Appendix L. So basically, Appendix L provides structured hierarchy of vessels. Next question, why is vessel order important in IVR coding? Okay, so as we have discussed previously, higher vessel order indicates deeper catheter navigation and technical complexity, which procedures are having more reimbursement value. Next question, how do you code if multiple vessels are accessed in the same vascular family? So in this scenario, we need to code highest selective level considered primary. Lower levels are included and not separately reported. So next one, what happens when different vascular families are accessed? So just here you need to understand multiple vessels in same family, multiple vessels in different families. So if the physician inserts the catheter into multiple vascular families, you need to code each vascular family separately, as you need to understand physician will treat them independently. So which increases the procedural complexity and documentation needs. So what is the common IVR coding mistake you encounter? So coding vessels passed during navigation instead of the final catheter tip position. So and one more error is misunderstanding vascular family hierarchy. So if you want to know vascular family hierarchy, please mention in the comment section of this video, and I will create one more video related to vascular family. So what happens most of the time, coders will decide IVR code based on the catheter passed through the vessels, but that is wrong. Just you need to code IVR code, or you need to choose IVR code based on the catheter tip location. Where does the catheter tip ended? Next question, while coding your IVR charts, what are the key things you need to check in the documentation? So first one is access site, or otherwise you will call it as entry point. So most of the time physician will use femoral artery as the entry point for the catheterization. So you need access point. Next, catheter path. So how does the physician will inserting the catheter? Whether he is crossing the aorta or he is stopping the catheter tip in the aorta. And also you need to find in the documentation final tip location, vessels imaged, and findings. If you find these all keywords in the IVR chart, you can code without any error. Next question. If a catheter stays in the aorta and contrast is injected, is it selective or non-selective? So basically, we will not code IVR codes based on the contrast flow. We need to code based on the catheter tip location. So here in this question, catheter tip is in the aorta only, but if the physician injects the contrast, it may go to the branches of the aorta, but here we need to select it as a non-selective catheterization as catheter tip is in the aorta. So next question. For example, in the documentation you will see catheter enters the renal cavity and catheter tip is in the renal cavity, renal artery. So what type of catheterization it is? So if the catheter tip is in the renal artery, you need to consider it as selective catheterization. Why means abdominal aorta is the non-selective catheterization. So renal artery means vessel needs to cross the abdominal aorta. So renal artery comes under selective catheterization. Next question. If a catheter enters a renal segmental branch, what happens? So these are the segmental, this is the renal branch, these are the segmental branches. So we will code only highest selective branch considered as a selective catheterization. Next question. How do you code if the catheter enters multiple branches within the same family? Here we need to code only the highest selective branch is considered primary, and we need to code additional branches included in the bundle guidelines. Next question. If a catheter enters branches from different families, how do you code this scenario? So as we have discussed previously, we need to code each family separately. Next question. So what is run-off angiography? Most of the time in the operative report you will see it as run-off, aortogram with run-off. So we have two codes. 75625 is for only aortogram. If the documentation contains aortogram with run-off, you need to code 75630. So basically what is this run-off angiography? So run-off angiography evaluates arteries from the abdominal aorta through the pelvis into the legs. So most of the time in the documentation, if you see run-off, physician is evaluating the peripheral arterial disease. So the medical necessity for aortography with run-off is peripheral arterial disease. So does run-off imaging affect catheter selectively classification? So no. So basically we will not code based on the run-off. So we need to code based on the catheter tip location. So imaging coverage does not determine catheter classification. So next question. What is supervision and interpretation in IVR? So basically you will see it as SI. So which refers to the physician's professional interpretation of imaging result. So most of the time physician will document this one separately from catheter placement. Next question. Why is imaging essential in IVR procedures? So basically as we have discussed, IVR procedures will be performed on small vessels. So in order to access those vessels, imaging guidance is mandatory. So using the imaging guidance, physician will manipulate the catheter tip into the diseased vessel. Using the imaging guidance, physician will evaluate the pathology. Next question. So can you code both catheterization as well as imaging? Yes, we need to code catheterization as well as imaging when medically necessary and properly documented. Just here we need to understand imaging interpretation is separate from catheter placement services. Next question. So what is bundling in IVR coding? So bundling means certain services are included in the primary procedure. They can't be reported separately unless guidelines allow it, like global surgery. Next question. Why IVR coding is high risk for medical coders as well as auditors? So IVR procedures have high reimbursement and complex rules. Okay. So if you code incorrectly, which can lead to denials as well as compliance penalties. Next question. How do you code if selective catheter placement is not documented? So we need to code non-selective catheterization if the documentation does not have selective catheter placement, so which reduces reimbursement and avoids compliance risk. Next question, why must IVR coders understand anatomy? So anatomy determines vascular families and vascular hierarchy. So without anatomy and vascular family knowledge, you can't code IVR charts. So if you want to learn vascular families, you can mention in the comment section of this video. I can create one more video related to this. Next question, why is selective catheterization considered technically advanced? So basically, selective catheterization needs precise navigation through multiple branching vessels. As we have seen in selective catheterization, we have in arteries 4 orders, in veins 3 orders. So in order to reach last order or fourth order, physician needs to spend more time. Next one, what is diagnostic IVR? So basically, as usual, in the common terminology, diagnostic means here physician will identify the disease of the patient using the diagnostic IVR. Next one, what is therapeutic IVR? So if the physician wants to perform definitive treatment of vascular or non-vascular, we will call it as therapeutic IVR. So what are the common examples like stent insertion, atherectomies, as well as thrombectomies, as well as embolizations. If you don't know this terminology, please mention in the comment section. I will create one more video related to this. Next question. So when do you code diagnostic angiography along with therapeutic IVR? Okay, if the patient does not have previous diagnostic imaging report or results, we need to code diagnostic angiography along with therapeutic IVR coding. Next question, what is the important concept in order to choose selective or non-selective catheterization? So always you need to focus on catheter tip location and vessel hierarchy. So you can't code based on the contrast flow. Next question, why is Appendix L important for interviews and audits? So basically Appendix L validates vessel order and vascular family determination. So basically whether coders or auditors need to use it to confirm accurate reporting and compliance. Next one, what is the most important learning point in IVR coding? Okay, if you want to master IVR coding, you need to understand vascular families, vessel order and catheter navigation rules. Okay, so if you know all these concepts, which will prevent over reporting as well as claim denials. Next question, what advice would you give to a new IVR coder? So I will tell IVR coder that please learn anatomy, documentation requirement and official guidelines thoroughly, and always you need to code based on the farthest selective catheter tip reached. Okay coders, so thanks for your time. I hope you have learned something from this video, and still if you have any doubts in order to understand these concepts, please mention the comment section. And also if you are looking for medical coding jobs in UAE, USA and India, please join in our WhatsApp group. Okay, and also if you are looking for any trainings like same-day surgery, IPDRG, SCC and CCS certification, please send WhatsApp message to 707-526-3939.